It's my great pleasure and honor to introduce our speaker, Dr. Yvonne Becher. Some of us may have known Dr. Becher for many years from her work in playwright. Dr. Becher is currently the Chief Executive of Child Development Center. CDC is one of the few centers in Hong Kong which serves children with special needs who are English-speaking and local Chinese. She is also the Director of Program and Learning of CDC. She is a registered clinical psychologist in Hong Kong, and also she has the qualification of clinical psychologist, educational and developmental psychologist in Australia. He leads the over 46 staff strong CDC team to deliver the individualized early intervention with expertise and passion. She also personally conducts diagnostic psychoeducational assessment for every children, run parenting courses and advice, and also provides seminar and lectures on early childhood plus or minus SEN. She promotes inclusive play-based early childhood experience where every child should have the opportunity to reach their highest potential. So without further ado, Dr. Becher will talk to us about the role of pediatricians and other professionals in early child development. Thank you.
Thank you very much, Dr. Leslie, and thank you, Dr. Bill Chan, for the invitation. So my topic is really from the child development aspect, but also as a professional, from the Child Development Center aspect. And so give you a quick outline, an appetizer, what's going to come. I'd like to sort of introduce the CDC as a resource to professionals as well as parents out there. And to that effect, I will intersperse sort of the role of the pediatricians and the CDC in early childhood development. So I will look at what are the service beneficiaries, who are the service beneficiaries, the programs that we can offer, and also, of course, assessment is one of my passions, and I will go into that a little bit deeper. And of course, some of the tools that we have to be cautious about how to interpret, how to use them. Because as I was preparing for this talk, there were actually a lot more commonalities, right? But there are also some differences how we approach this topic. And so it might be a good starting point for discussion, or what can we learn from each other? That would be a really good outcome of this presentation. So the Child Development Center, in a nutshell, is a registered NGO that's been around since 1976. That means we're celebrating our 50th anniversary this year, anniversary of providing special educational needs services for the young ones. Our mission, of course, is for every child to succeed in their unique learning journey and empowering their families. So to us, that will come through later. It means, sort of like a strengths-based approach, looking for what each child can achieve. And to that effect, we actually have two centers now. One is, as you probably know from the government services, an EETC, an Early Education Training Center in North Point, and also a self-finance center in Fortress Hill. So you may know us more maybe from way back, from the Matilda International Hospital. That's where we were housed for a long time, but we were never part of them. We were always independent. Then we had a journey down to Wan Chai and eventually our two centers where they are now. So it's quite versatile. You see, we offer assessments, that's where it starts, specialized group programs, and individual therapies for children with really a wide range of abilities. Now, the EETC, of course, is limited to the age of 6. That is from the SWD. But our self-finance service offers services from birth to 16 years. And that is in English and Chinese. So it's really helped us in our 50-year journey to develop to that expertise level. And of course, we provide parent education. We would like to think of them as our partners, offering them advice. Sometimes it's short-term, sometimes it's long-term, but part of that journey means home visits as well. So you can see here some of our current layouts of, sort of like some waiting areas that we've developed in the two centers. There's our what we call the gym, which is a motor therapy/sensory room, and some of our classrooms. You will see some of these pictures again, because now I'm going to intersperse my first sort of thought on what's the role of pediatricians and CDC. CDC as an example maybe of an NGO that offers early childhood development services. The role, I think, is to create already an environment where when children step in, it's welcoming. Families must feel welcome, and children to have them at their best, to have them engaged and support everybody in a child-friendly way. So to allow that, or to facilitate that, we have some play facilities in our waiting areas, and I'm very mindful of hygiene arguments. You know, toys get lost, toys need to be checked and cleaned. And yes, we are not 100% successful at that. We always, must find toys, must replace toys. But I think it's very important for the children that they think it's somewhere where it's play-based. I sometimes maybe make the mistake of wearing a white blouse and I look like a doctor, unfortunately, and the immediate impact is that some children start to cry because they're thinking I'm getting them or giving them a needle, right? So the environmental impact is very crucial, especially for children with special needs, because they are very sensitive to these things. And of course, we allow the children to take a toy from the waiting area into, let's say, down there, the occupational therapy or motor therapy room, or any of the other rooms where they get their therapies to help the transition. The parents, of course, are allowed to come along. So all of that is in support of being a child-friendly center. So, of course, we want to avoid the flimsy, unsafe, boring toys. That's a given. And, yeah, we are still working hard on this as well. So let me look at the the next slide. If you could have that, thank you so much. So that gives us a bit of a picture of the uniqueness of the CDC. Although we're one part of the many EETCs out there, we're a bit unique. One of the uniqueness is maybe I'm not the best representative in terms of ethnic background, because all of our staff are actually bilingual or trilingual in Chinese, Cantonese, Putonghua, and English. But we do maintain a very healthy adult-to-child ratio where there's one adult, one staff, to 3 children. And we make sure that happens throughout. Of course, in one-on-one therapies, it's one-on-one. And of course, you can see there on the wheel, we have interdisciplinary expertise. There's everything, and if you're looking very, very carefully, what we're missing is a physiotherapist and a pediatrician. But apart from that, we have a music therapist in addition to our speech, language, and occupational therapist. To me, that's a given, right? The social worker. We also supplement with ABA therapists. That's in our self-finance center, of course, because the government will not cover that. And psychologists we have, as well as special childcare workers. So we all work together to really provide diverse and engaging learning experiences. And I can honestly say the 100 children in our EETC, the 100 children in our self-finance center, all have an individual learning path. So that's quite a unique achievement, I think. We allow them to have trial classes. Like I said, they have a personalized learning plan. And then there's a lot of communication with parents that we try to achieve. So some of the pictures down there will sort of support that, and you will see some of them more in the subsequent slides. But you can see there on the very left is actually a group session, a group program there. You don't see the children lining up, outside the photo. And that teaches them the social skills. So we emphasize the groups with a conscious mind that they need to learn the social skills that they often cannot pick up just by doing individual therapies, which is on the right. So there's a group program on the right, but it does show there is room for one-on-one individual training and experiences, right? So all in that, it is possible to have that in a very unique way. So, yes. So I move on to who are the beneficiaries. This is from a CDC perspective, but I think we share some of that. I call it the United Nations, actually, because we offer services in Cantonese and in English, and branching out more into Putonghua. The families really come from all walks of life. Socially, culturally, language backgrounds. Just because they're not Cantonese speaking doesn't mean they're necessarily English speaking at home. From the EETC perspective, just to give you an idea, the government has allocated us 54 Cantonese-based places and 46 English-based places. So it's very 50-50, very balanced. And then in our self-finance center, we also accommodate some of the government TSP places, training subsidy program places. Where we are predominantly in English, but we also, cater, especially in the individual therapies, for Cantonese Putonghua speakers. Like I said, all staff are, many lingualists, and we're very proud to have some staff that are from ethnic minority backgrounds, so that we can offer Hindi, Urdu, and Punjabi, and some other Indian dialects that I'm not that familiar with, and Tagalog. So that's quite a unique offer that we can give the community. And our parent information booklets, for that reason, are published in 8 different languages, not just in English and Cantonese. And that follows some of the efforts that we see from some of the government departments as well, which is great. If needed, sometimes there's a language we cannot cover. We do tap into CHEER, the Center for Harmony and Enhancement of Ethnic Minority Residents. They are an excellent resource, if you have to have a translator, in-person translation when you deal with some parents. And of course, we take extra care. We've learned this over the years, to take extra care to explain to families of non-Cantonese and non-Western backgrounds what this early childhood intervention and even development means. They are just from such a different cultural background sometimes that, we cannot assume that they understand early childhood as we do. And we've seen that. So let's look at, with that in mind, look at what's the role of pediatricians and that CDC as a, sort of engaging way or name for all the different professionals out there. What we don't want, but it happens every so often that, families treat us like maybe a tutorial service, which we of course are not. We are there to give intervention for additional needs. So we don't want to fall into that trap. But we have Chinese families, who enter the English programs, and then we discover that is not for the right reasons. Because how we, and of course as pediatricians and as a psychologist myself, we place the children on the SWD referral lists, right? And we have to choose, do you want to go the Chinese stream? Do you want to go the English stream? And of course, I'm sure everybody's first criteria is to use the child's developmental needs and match it with the available program. So it's a good match that addresses those needs. Sort of on the fine-tuning side, what I always get encounter and get faced with is to ask, what's the mother's tongue? What's the mother tongue spoken in the family? And will they reside in Hong Kong long-term? Where are they going to go next? That may determine if they want to English versus Chinese. There could be Chinese families who are planning to go to an English-speaking country. So that needs to be taken into account. On the reverse side, we have ethnic minority families who we honestly have to ask, can you really sustain the program beyond early childhood on an international fee level in school? Right? That is a question they have to ask and answer, and then we might have to start the Chinese programs with these children because they will end up in local special needs or mainstream schools. So having said that, where's their location? Besides us, there's on the EETC side, there's only Watchdog that offers English-speaking services. And then one, of course, a new SEC service in North Point. So location is a big factor if the family comes from New Territories or Kowloon. So are they available? Can they come to the center? We often have to support travel costs for some of the families, right? It's not a given. And last but not least, there are cultural limitations where we have seen agreement from a mom from an ethnic minority background that she would like her child to attend intervention, but there is a cultural difficulty that she may not be allowed to travel by herself. A male partner or member of the family has to accompany her. Is that possible? Is this person working? So that I have seen actually interferes with the child receiving the services that they really deserve. And that is something we have to work on. We have to not just discard, wipe off the slate, but we have to work with it and try and gain their trust and really hope that they can join us in helping their child in their journey. So this is sort of, in a nutshell, this is how I want to show you that some of the programs that are possible, the variety of program that is possible, even within the, let's say, the constraints of a social welfare department framework. I'd start on the left, where I call it the early intervention groups. Now, how we run the groups is a maximum of 6 children, and following our ratio, there would be 3 adults working with these children. They get their biannual developmental assessments so that we can really track the goals. We set goals each time. We need to see where they're at in 6 months and so forth. So they see the interdisciplinary team there that's working with the children, typically a special childcare worker or SEN teacher, occupational therapist or speech therapist. And of course, we get drawn in as psychologists sometimes, for the more difficult behavior management cases. We run it like a little bit like a kindergarten. So the children come for 2 hours, and there is a free play time, and that's deliberate. We find a lot of young children do not know how to occupy themselves or do free play by themselves. They are so adult dependent. It's a little bit scary to watch. So for 10-15 minutes, of course, an adult is there, but it's really child-led, and that's very possible for children with special needs as well. Then we launch into it's like a circle time, as you probably know from kindergarten. We call it then station time, where we divide the group into smaller groups of 1 or 2 children. And there they see the therapist individually. They work with an occupational therapist for 20 minutes. They move on to the speech therapist and then a special childcare worker. So there's that room for individual input. But then they go back into a group. They might be reading a book together or going to play a group game together. So that is the added value of the group programs. On top of that, of course, we have the individual. As you know it, the individual sessions traditionally, very typically as we know it. And some children need that. Some children are not ready for the group, and we recognize that. And so we dedicate their 2 hours that we provide them entirely, sometimes to individual therapies. We also have added in a music therapist, which we lately have found of extreme value because of what I think is almost a significant increase of children with selective mutism. We have seen so many more these last few years where we find the music therapist is a valuable addition to the speech therapist, really drawing out the children on the emotional side. And we have added, like I said, on the self-finance side, the ABA therapist. They really work from the children from scratch that really need that really early intervention of putting together cause and effect and even sitting down for a short period of time before they're ready to learn. So in addition, we're very proud to say we have focus programs. They have... I do it a little bit by age. There's the food exploration group, which is the latest addition to our group programs, where we really address the picky eaters from a very young age, preferably about 2 years of age, maybe 18 months. And that is with training. There's specialist training in what is called the SOS feeding program. Then we focus some of the children to our what we call social stars, social superstars, or Lego club, where we've really focused just on social skills building. And then we have an additional attention group where we address attention and sensory skills and needs as the predominant need for a child. In our EETC program, we have a special school readiness course. So towards the end of the year, which is now in 2 weeks' time, we have selected some children with low executive functioning skills will enter the mainstream kindergartens, primary schools, and we give them a little boost and really have a simulation of a school classroom. We even put in substitute teachers so that the children with autism in particular, right, get used to the unexpected, the non-routine. So that's been running for a while, and that's extremely powerful in helping the children. And we also have animal-assisted therapy, where we bring in a dog. He's a trained dog under a dog therapy program. And we have tried that, and with great success, seeing the children opening up, having more literal contact with the real world, starting to have eye contact, and even making sounds when they're nonverbal. Because, of course, we have the whole range of children, right? We have anything from a mild lisp to really children who are waiting for an SCCC place, and we know that is a higher risk that they really need more intensive therapy with. So all of these together really complement each other in a nice way. Last but not least, we have the full assessment profile there, where maybe it's just a developmental assessment of speech and OT, the psychology, the psychoeducational assessment, and of course the parents sometimes just need a consultation, or they need a parenting program like Triple P. Or we have the happy parenting on the Cantonese side, or just parent seminars that we offer online quite frequently. So all in all, that is really what we feel is a really comprehensive program to address the early child development needs. So here are just some visuals, and I'd just like to say these are not just flimsy little outings, right? There are learning opportunities for children and families. So you see here the Disneyland photo, or the children going to the beach with their families. That is deliberately done so that the children and the family sometimes have sometimes leisure time together. A lot of children with special needs, have a timetable that's dictated by therapies, by intervention, by input. And there's a lot of pressure on the parents as well. So sometimes we do these outings just to emphasize, why don't you and your child have a really good time together and just have that bond building. Some of that is also with a little bit more of a deliberate therapy input, if you like. You can't see this here, but this is in the Hong Kong U clinic, the dental clinic. And they're kindly inviting the children that we have once a year, and they take them into a simulated dental office. They sit in the dental chair. This picture shows they get to look at their parents' teeth with, very, very safe. And then eventually we put them in the chair and have their teeth checked. That is such a big help to those children who are sensitive to these environments, but also to the children with autism. Especially they are noise sensitive, young beings. And so that to take that fear away from what is usually an anxiety creating environment, but it's so necessary because of a lot of children with special needs also have very poor dental hygiene. Right, so it's hopefully it's a step towards helping them and their parents bridge that need. Below that, you see this is our dog therapy. There's a dog, and if you can see that, there's a child looking at the dog therapist adult. Is a child that usually does not make eye contact easily. We found that extremely helpful. Right next to that is our one of the music therapy sessions. Again, it's engaging children in a non-threatening, non-verbal way that we usually would not have seen elsewhere. Below that, we had some yoga sessions. We still have yoga sessions in our self-finance center, again with a caregiver, and it's just to do something together that's not threatening, is without a goal, finally, and just to build the bond. Of course, we have our cultural winter celebrations, a must. And here, there's this first start of our food exploration, where they sort of in steps, sensitively, desensitizing the way, get used to different foods and different food groups, or even just putting the food in their mouth. That is a very, very big concern to parents, as you can imagine. So I think looking back, this is coming back to our topic here, the role of the pediatricians and the CDC, I very much see a shared responsibility. And the shared responsibility is to bring the child to the place where they should be and to address their needs, and hopefully, to have a bridge for their future journey in school. Of course, we all have the choices to refer, and there's the infamous list of the OPRS, the EETC, the IAP, the residential SCCC, and so forth. And of course, OPRS, as we know, is in transition. It has now the Tier 1 and the WAIT programs, and it will be soon standing on its own in a school-related, school-based model. From the CDC's perspective, I think we have the advantage. It's not just an assessment center, right? It's not just I see you once and then I refer you on. Because we provide the services as well, and because we have the self-finance center, we have the luxury of seeing a child over time. So sometimes on first encounter, you may not see exactly what's going on. And also we don't need to see a diagnosis, right, to have intervention put in place. So we really want to give an opportunity for the ongoing monitoring. And sometimes that has been extremely valuable in replacing a child. So that a child might have been in a group, and then after 4 weeks we see that is not the right place. That is difficult in the government system, where once you're placed and you have to unravel, the whole administrative path, that is quite a challenge. But it's easier to do in a self-financed center where we can say to the parents, look, we've tried, we've observed, we've monitored, in consultation with you, do you think you'd want to try this other program? So that's a really nice addition to what, of course, we can offer on the government side. And also, sometimes it is still a long wait list, despite what the government sometimes claims. There is still a wait list for some of the EETCs and SECCs, and some parents don't want to wait, right? So we're in the position to offer something where they can just go while they're waiting, maybe for a more affordable government place. But we also give them some financial assistance while they do that. So they can also get the intervention then immediately, as you can imagine. And like I said, there are social elements, there's social element opportunity, and yet it's very individualized for every child. So that's our role. But for the pediatricians, this is how we would like to really benefit from a pediatric input. We don't have the resource, and I sometimes feel that's a real lack when I want to assess a child and make a diagnosis, is how much is medically contributed. How I see a child with allergies. I see a child is itching and having red rings under their eyes. I'd love to know, of course, are they having any allergies? Is there a nutritional deficit or deficiency? So we have to refer out. We have to say to the parents, go out, consult your GP or pediatrician, and then could you please share those results back with us, so that I make a firmer diagnosis. So that's sometimes challenging. And then on the other side, when we have confirmed, especially on the side of ADHD or a little bit older anxiety, we don't, of course, have the facility to then do a medical or pharmaceutical intervention trial, or even, go down that route. Again, we have to outsource that. And that, I feel, is a big contribution that we are lacking, unfortunately, and that we would welcome any pediatricians input in. That would be a great addition. Apart from also, you also refer, like we do, of course, to all the SWD services. Okay, so here comes my passion. The assessments, right? Where do we go with this? This is something we all have in common, but I also feel there's some underdiagnosing going on, as well as overdiagnosing. And I think we're all susceptible to that, of course, me included, because there is no such thing as a blood test, as a firm number that tells you what's the diagnosis in terms of development for each child. Now, in terms of underdiagnoses, disproportionately, any statistics will tell you that, unfortunately, especially EM families or any specific demographics are usually disadvantaged in that sense. That means they're underdiagnosed. They're not identified as maybe the main population. And that leaves many, many children without necessary accommodations. Now, I've given this several trials, several thoughts. I've watched other programs. And I think the conclusion is lately that rather than expecting these families and these demographics to come to what's available in the community, I think it needs to be the other way around. It needs to be that we go to those demographics, that we reach out to those EM families, not to say to them, reach out and say, here's the center, come, but we literally have to go into their communities. And we've done this successfully twice in the last year. We've done what we call family fun days. And family fun day means, yes, there are some fun activities, but also we give a talk on early childhood development, and we offer a screening sort of exercise where we pre-screen the children to see how many would be referred for further assessment. or how many should be maybe looking into some further intervention. So that has been quite a successful program. It's becoming more and more popular. We, of course, have to work with the community representatives. Sometimes it's their elders. In one case, it was also the head of a Sikh temple. And it's been quite successful in that way. So it's not enough to just say, here are the pamphlets. They are available in your language. It doesn't convince them. I don't think so. But also, moving on, we know there's some gender discrepancies. Most of the tools have been calibrated and normed against male-presenting behaviors, right? So we need to be aware of the females that probably present differently. A lot of females with mild autism are very capable of masking what we think would be a sort of an autistic trend or a non-social trend. They're kind of very good at playing over this, right? Or internalizing and just presenting as shy. So we need to be more aware as anybody who's doing assessments, pediatricians and us alike, so that also there are, like I mentioned, some other socioeconomic and racial factors. So similar to the EM families, some families from lower socioeconomic backgrounds don't have the insight or, don't want to admit. We still have those families that really, really don't want to be identified, or there's a large cultural bias. It's still a shame, perhaps, to admit that your child has any special needs. So we need to overcome that, again, by gaining their trust. And it helps. We know this because we do have EM staff in our community that gains the trust for some of these families. And of course, co-occurring conditions, not to mention that some of the very high-functioning people or children with a disability or some special need are very good at masking this as well. And so we need to compensate for any of these deficits. And often they may not be detected until further on. And I'm just assessing a young boy, 14 years old, who was assessed, not by me, but here in Hong Kong at the age of 5, suspected ADHD. So they came to me at the age of 10. I said, yes, mild ADHD and ODD, oppositional defiant disorder. And then now at 14 and a half, we're seeing more and more signs of autism. So it is a progression. It is not just what it is in day one, but you have to revisit and you have to go with the flow, what you see. So I think conservatively, I would say if you suspect something, follow up, right? Don't just let it be and say, like in the old days, oh, he might grow out of it, or oh, he's a boy, he'll be better. I think that's, we know, is outdated, but we still sometimes fall into the trap of all the above points. And I really wish that we do not wait. An at-risk child is good enough reason to make a referral or to do some intervention. Early intervention is key. If we know anything, research tells us about early intervention, it's the earliest is the better. I think that we can all agree on. And then, of course, on the flip side is the overdiagnosis, right? The sort of push for, yes, there's ADHD, or even worse these days, it's there must be autism. So there is a trend that we I think find from the system, from the parents, from education, there must be a diagnosis. Unfortunately, I have come across their school will not provide intervention unless I would have come up with a diagnosis. And I said clearly, these are the deficits, these are the weaknesses, these are the needs of the child. The child is at risk, but is not meeting the criteria to make a firm diagnosis. And even though that's said, the school refused, as they pushed me into a corner and said, if you don't give the diagnosis, the child will not get intervention. Now that is a concern, and that's something I deal with case by case, right? But you have to be aware that you cannot just be pushed because the system says so. But it's also, of course, the boundaries of ADHD and autism can be a bit fluffy and fuzzy. We don't have biological tests. It is a subjective call. Recently, I observed and tested a child with a colleague. We don't often do that, but we had the opportunity, and we both sat in and we both scored this child in terms of autistic criteria, and we both came up with very different conclusions. Right? Especially difficult because it was a teenager who was not very verbal. So that was a bit of a challenge, but it made us both aware of the other person's point of view and the fragile and caution we have to take, the cautious approach we have to take when making these permanent diagnoses sometimes. And of course, sometimes we see what we think very obvious signs, right? The boisterous behaviors, and we think, oh yeah, must be ADHD. But again, caution, don't throw caution in the wind. One symptom alone, we know this as professionals, don't do the trick, right? Just because a child is tiptoeing or just because the eye contact is weak, it does not mean there is a diagnosis. It means to investigate further, for sure, but it's not there to just follow the parents' trend and saying, see, I have parents come in and say, see, my child's tiptoeing. Is it autism? Right? And there's an anxious parent in front of me, which I recognize, but it's also up to me to find out more, to do more investigation, and to gather the data to come up with either or diagnosis or no diagnosis. And of course, yes, the institutions, they do give us pressure. It's sometimes should we err on the side of giving this diagnosis? Like I said earlier, we don't want to underdiagnose, but it's not to give a diagnosis just for accommodations. There is a trap, especially these days for final year students that approach IB or, the local big assessment, and suddenly they want accommodations. So I get a lot of assessment requests saying, oh, yes, can my child, he can't focus. Can my child just get some accommodation? What does that mean? 10 or 15 minutes longer in an exam. Okay, so this is very, very delicate. Now the IB and the other boards are more on top of this. They say if the child does not show a track record of having had accommodations or a track record of having been investigated for possible, additional needs, then they may reject that, even if that one-off report comes in at the age of 14. So lucky, the boy I just mentioned, 14, he has a track record from age 5, 10, and 14, so he may be eligible. Okay, just on the assessment side, I'm going to go a bit local because, of course, for many, many years, we have faced this issue in Hong Kong, and at Hong Kong U, I've been involved in developing a childhood development measure that was localized, and we've tested many, many children. Also the same for Inter-Asia. Many countries wanted a scale that was addressing early childhood measurements in the Asian context, because a lot of the early developmental tests, even psychoeducational tests these days, are still based on Western middle-class populations, right? There are even faces in the West where not everybody is Western white middle class. So this can, of course, lead to misinterpretation, lead to misdiagnosis, and there are many more linguistic and cultural backgrounds to take into account. Now, very, very, very exciting to see was as we were developing something at Hong Kong U, the Department of Health was developing something, and other universities are developing. So now we have localized tools tailored to Cantonese and local cultural norms, which is so exciting. For example, we've got the Hong Kong Comprehensive Assessment Scales for preschool children in our center. To my detriment, it's only in Cantonese, and you have to be trained in it. And it's very difficult to get that training, actually. So, but my other psychology colleagues are well versed in this, so this is my luck. We have speech therapists, of course. They learned the Hong Kong Cantonese Oral Language Assessment Scale. Again, locally normed. We have the intelligence scale, the WISC, normed in Hong Kong. Now, that has created another problem, though. It is now discriminating against the non-Cantonese speaking population, where unfortunately I have seen families come to me and say, I do want to go to the CAC, I do want to go to the Child Assessment Center, but they did not have the tools in English. They offered me tools in Cantonese. So, I mean, it's fair to say the majority of people in Hong Kong, of course, are Cantonese speaking, but it also deprives the non-Cantonese speakers of accessing government services in that sense. And so they are, pushed into the corner of having to pay for it privately, which is okay in some cases, but not okay for some ethnic minorities, right? So we have this dilemma that I think we have created by trying to address one problem that put Hong Kong's main population at a disadvantage, but now we have our own problem where we have minority groups that cannot be assessed through these local tools. So it would be wonderful to see if that could be extended in some ways, obviously language and culture being the biggest issue. Okay, I just divert into some of the assessment tools. This is from my experience as a psychologist and use, and you either use them or you benefit from the diagnosis or from the output in some reports. And of course, the ADOS-2 is hailed as the golden standard of diagnosing autism. And everybody is supposed to be using them, and it's almost like if you don't use it, well, how can you diagnose? But in the past, we have diagnosed without it. It is a good tool, but just be super, super cautious. It is almost first of all, it's an over-reliance on this tool, that everybody says you have to have this and nothing else counts. But we also see a lot of false positives on this particular tool. It is almost difficult to prove that you are not autistic when you're going through this tool, right? So it's a tough one. It's also not always appropriate for some of the older children. They find it a bit childish, and yet we put through this 14-year-old, and he just goes, well, why do you want me to, show you how I play with certain toys? There's little scenarios that come with the ADOS, if you know it, where you put on some items and you're supposed to show how you interact with them or play with them. So, it's just one piece of the puzzle, like, as always. So do supplement. Don't just rely on this ADHD or one autism-like ADOS. There could be other reasons for shyness. There could be other reasons for non-conforming, non-complying. And when I refer back to the case where I diagnosed together with my psychology colleague, it was good that I saw this child doing the session and really not doing well on this ADOS, and then going out to the waiting area and completely different behavior towards their parents, right? So that is also a valuable assessment tool. To me, assessment actually starts in the waiting area the moment I lay my eyes on the family and on the child. So caution on the ADOS. And then the CONUS 4, you might have come across, that is a questionnaire-based tool that's supposed to be reliable for ADHD diagnoses, right? And always emphasize that a high score alone cannot independently diagnose ADHD. So what happens? Parents fill out this questionnaire, parents and teachers fill out the questionnaire, and there's also a self-report. And it gives you a kind of a high score or above average score, elevated score in terms of impulsivity, inattentiveness, but also, interesting enough, on depression, anxiety, and emotional regulation. And then it gives you kind of a score. It says, your percentage that you have ADHD or this child has ADHD is at this level, and it's very high. Now, you have to be really, really cautious that this one score does not mean you have ADHD. The one score says you behave or exhibit behaviors that look like you're inattentive, but it doesn't tell you the cause of why it looks inattentive. So I always quote the example of, if you put me in a Chinese class, I don't speak Chinese, I don't speak Cantonese, within 10 minutes I'll be clueless, I don't know what's going on, I'll be looking at the ceiling, I'll be rolling my eyes, I'll be restless in my chair. Now, a teacher who sees me would go, whoop, go have yourself tested, young lady. Is this ADHD? So just remind yourself that the CONUS 4 score does not tell you the cause of the inattentive behavior that it captures by the score. Right? It is subjective reporting on top of that, so you also always have to put that into some context. And then the last, but not least, sort of caution that I want to say is it's a CPT series, which is a nice series. It's a computerized assessment tool that for the young ones, the KCPT, It puts a child in front of a laptop for 7.5 minutes. They all get very excited. I think they're playing a game. I tell them it's the most boring game. I want to see how you last on this. And for the CPT, the same thing is for children 8 and above. They get equally excited. Same story. And I say, it's for 14 minutes. I want to see if you can do this. So basically, it's meant to capture attention, vigilance, sustaining attention, and that sort of thing. But it's been proven to actually be a weak predictor as a standardized test. So do not rely on it entirely. Again, it is a weak predictor of having ADHD or not. It lacks discriminant validity. That means children with reading disability or reading disorders have done equally as bad or well as a child with ADHD or ASD. So it doesn't really discriminate well. False positives comes out. It is a good adjunct. It's a good support. But also it doesn't differentiate between the different ADHD subtypes. It has really limited validity for those who are faking it, I hate to say, but the ones who want accommodation for later exams, right? They might want to fake the condition. And honestly, it doesn't pick up those very well at all. It claimed, but it wasn't. And then there's also the task boredom. There could be genuine boredom after doing this for a while, but does not necessarily mean as an attention deficit. So really just use it as an adjunct, maybe together with the Connors 4, with observation doing, the assessment, of course. And also I've noticed, sadly, in some reports that the verbatim analysis report that comes from this test, which is wonderful. The child does it on the laptop, and then the computer program, the software scores it, analyzes it, and out you get a 4-page report. And it says it on the bottom in very small print, do not disclose this report directly to parents. And what do I see when the written report comes out from the professional? Psychologists alike, verbatim copy of that very analysis report. Why they caution against that is because it is out of context. The parents don't know really how to interpret the data. It needs to be an interpreted version that goes into your written report. So just a word of caution on that. Okay, so I think I've sort of looked at early childhood development through the CDC eyes, but also to me that means through the eyes of many other professions. And of course me particularly as a psychologist, but I see a lot of parallels with pediatricians. I would love to have the added value of medical input from pediatricians. But just to summarize it, it's really when suspecting or diagnosing, it is so important how we deliver the news to parents, right? Sometimes we are first deliverers, sometimes we do it as a second opinion, an updated opinion, and you need to do more than just deliver the news. Oh yeah, your child got ADHD, your child got autism. That is big news for the family, to say the least. And really, the next step or the flip side of that coin is to give the family a clear pathway and a path forward and choices, informed choices. I've seen parents who say, the doctor or the social worker or psychologist said, oh, we should just do the OPRS. Oh, okay, yeah. So how do you know this is the right thing? Do you know what OPRS is? No clue. Parents often do not know what the acronym means or, what is their other choice. We explain to them there's an OPRS if you want to go the government route. There's an EETC, an SECC. Absolutely means nothing to them. You need to sit down and explain each implication. What does it mean when your child gets EETC services or SECC? Why do you think somebody should go to an SECC? Your child should go to an EETC. What's behind that? So really, it's a conversation that you should have with the parents to give guidance, resources, support, of course. There needs to be some grieving sometimes, and leave them with some answers or things to think about. when we do assessments, I'd like to get my social worker in. I have the parent on site here, sign that we can give your data to the social welfare department. And some families are just not ready for that, right? So we need to give them time. They go home and then we follow up with them and say, have you thought about what we asked or what we suggested? Do you have any more questions? So it really is a process for the parents that they make a good consent, a good decision, fully understanding what the implications are. We'd like to see really make them make an informed choice on how to navigate their child's developmental condition. And it keeps changing, right? So we really need to help them navigate good and bad. Okay, so I'll leave you some of the resources. I'd like to sort of also suggest use the CDC as a resource. We're there for professionals, other professionals. We're there for the community. There's our website. There's all our programs on there. We also have, too much. Sorry. We also have Facebook, Instagram, YouTube. The YouTube channel that we have actually captures a lot of the parent seminars that we put out there, and they are both in Chinese and English. So tonight we have a parent seminar in Chinese that will do P1 preparation. So the young ones, the 6-year-olds who are going into either mainstream or SEN school. That is purely for the parent community. It's open to everybody, and in 2 weeks or so, we'll place that onto our YouTube channel. Tomorrow will be the English equivalent. So that's how we try to also serve the community and be a resource. Okay, so I sort of conclude here and leave some room for questions.
Sure. Before I leave to the floor, really impressed by your talk. From your presentation, from assessment to intervention, very holistic. So it echoed to what I learned from other experts that we should not only rely on assessment tools and questionnaire especially. And also another point is our role is to navigate a parent after the diagnosis to make a right choice. And also the variety of support service provided by CDC despite of the limited resources provided by the government. Thanks so much. And also you mentioned about the dental care for SEN kids. Actually, I am going to present a talk 2 days later to a group of pediatric dentists in the ASM to let them know the needs, in particular the ASD, ADHD, and intellectual disabilities, and also the skills to manage the teeth and in a dental clinic.
Yes, and can I just add, when we do that program, it's actually a two-way benefit. The families benefit, like I said, the children benefit, but also they said they put in their student interns. They're all postgraduates, right? So they're all dentists, and they inviting us actually to learn how to handle the children with special needs in the chair. Yeah. So it's a win-win.
Yeah,
right?
Especially the sensory issues, the behavior and emotional issues, and the communication skills.
Yes.
So I start with some questions first, a couple of questions. How to choose between the preschool rehab service from ETC, OPRS, ICCC, and SACC? And the following question is, quite a lot of local Chinese and some from mainland choose international school for better futures. And some of our kids learn a lot of English vocabulary, mostly from the phone. Smartphones or some iPad, so the parents think they are good at English. So your view, please.
Yes, we do see those families, but it's just more than language as well, right? We do want to look at the child holistically. We take into account where they learned it, and it's very obvious some of the children had learned it. Let's say, literally, like you said, they learned it from a device or through some other means. And my dread is they're learning from a flashcard. And you can tell this language learning is through everyday interaction. It is not learned. It's not like we learn in school. We learn a second language in school very differently from learning a language that we actually use and live with. So we approach it by looking at, yes, the language fluency, do they understand something that's outside of a context of a rigid routine question? So you can even sometimes say to the parents, I say to them when I see a deficit, I say, use different vocabulary, widen their vocabulary. For example, if the family always uses, oh, there's a small ball, or there's a small something. Yeah, in English, you can use so many other words. Tiny. Now, if I say to a child, there's a big ball, and they go, yeah, there's a big ball. But if I say there's a huge ball, and they look at me absolutely puzzled, that to me is already a deficit. Their vocabulary isn't large enough, let's say, age appropriately. So we take that into account, of course. We take into account what are the possibilities of that being rectified within the family context. Sometimes they invite an English-speaking domestic helper, right, to correct this. And again, that is, I think it's set with flaws because the domestic helper's mother tongue is not English. So they're learning English from a second language speaker. It's again, so that's a consideration. And then really we see what's the rest of the development, of course. Are they also, is it just language? Then there's a second language problem. Can I really justify sending a child to a rehabilitation service on those grounds? If I don't see any other reason to send a child to an intervention that is costing the government a lot of money, I'm hesitant to refer that child. I'd rather refer them to a good tutor, right, or first language speaker. So that there's a fine line between is a developmental need versus a second language need.
So what is the advice to the parent? Turn up in your center because they think their kids are good at English or they want to plan a better future, and on the other hand, they actually put it in an international school. So they want you to train up their English, especially they have special needs.
I usually say, here's a good list of, where you can learn language. Having said that, I also encourage them maybe to learn it naturally through other play groups, through extracurricular activities. That's a natural ground where children learn language better. We don't provide that. We provide each group, each child will have their goal program, and that's how we structure our programs. We don't structure it to learn, to learn better English. So we structure it to help a child who has true language deficits. So I explain to them that we may not meet their child's needs in that way. We're missing the target in this case. So you're much better off going to a natural playground, an extracurricular activity, right, where you pick up from native speakers.
Yeah, agree. So we shift a bit the topics. How about the EM? So is your view about EM learning Cantonese or keep on their language and other challenges?
I do believe that even children with special needs, unless they're very severely delayed, are capable of learning several languages actually at the same time. So mother tongue is very important. Mother tongue at home is a language where you connect with a child. The children connect with their parents. It's the child where they become most fluent in expressing their emotions, right? Even if they're bilingually as adults, there will be a stronger language, and that language will be where they express emotions. But at the same time, they can learn a second language. And if they stay here long term, I always encourage them to learn Cantonese. Yes. It is such an asset. It's a must almost. It's not an asset.
And more than that, still are lots of challenges. The economic, financial issue of the family. Exactly. Being a mother, need to listen to the father, right? And also, and the cultural belief on whether the child has special needs.
That is sometimes it's a dilemma. And I recently came across a family. We were called in from a mainstream kindergarten. The child was already getting OPRS. The kindergarten tried what they could, and it was an EM family background, and it was clearly a child that needed to be placed in an SECC, right? The needs were much, much greater. So we explained this to the mom. She kind of and ahed. I think eventually she said yes, talked over with dad, and dad said no. Because for one thing, OPRS is convenient, it's in the kindergarten. And it didn't mean much. We already had worked out this would be the SECC for you in your neighborhood. This would be the bus route you take. So we went to that detail, right? But it was not, from the father's perspective, not appropriate to have to admit that the child had special needs, even though we said it's to your child's advantage. You're missing a golden time. It was very difficult, and sadly to see, we did not win. It's not a win. It's it's a must to this child.
Even we hold up their hand to take them
Yes.
through to the center
Yes.
with money and the routes, everything.
Yes,
Yeah.
and their belief is so strong. So this is where I think we sometimes have to start from the basics of coming across how important early childhood is, right? It's not just for the SEN community. It is such an important window. This child that I just mentioned also had an older sister. And so we tried to explain to them, what are the opportunities for this older sister and how important it is. But that cultural difference was just too big, unfortunately.
Yes. So it takes time, I think.
It takes time.
And before I leave to the floor, the final question is, what is the view about the current concept of neurodiversity and strength-based model?
Neurodiversity, now that is our trendy word at the moment, isn't it? And I think it needs education. It does need education in the community. I now see the term completely misused. All of a sudden, all disabilities are neurodivergent, which they're not. We're talking about neurodevelopment. So ADHD, ASD. We just
So many is talk about Down syndrome,
Yes, so it's misused,
Yeah.
and I think it also puts everybody into one category when we really should still keep some individual, perspectives, and not stereotype and say everybody who's neurodivergent is like this. That's the danger we run into. But I think we are in the position as ECD advocates in our professions. We are in a good position to advocate and to understand and to make this to the general community, make it accessible to the general community, what it is.
It's good, the concept of strength-based, but need to be taken caution.
Yes,
Yeah.
strength-based, definitely. I think we breathe and live strength-based, right? We want the best for the child. We cannot ignore the weaknesses. We want to use the strengths, but this neurodivergent advocacy and confirmation, everything has to be, it's gone to the other extreme. We need to bring it back to a happy medium. I
Agree.
think.
Yes.
I think like Yin just asked a question about the newcomers from mainland China. I think you both have answered that. I'd like to tweak the question a little bit because I learned from my colleagues in the neonatal unit that almost like half or more than half of the babies born these days are of Southeastern Asian origin. So of course we are not familiar with that. Even you said that in your center you have many workers speaking different dialects, different languages, and they come from ethnic minority. But are there any differences in the assessment tool and also the intervention to this group of Southwest Asian newcomers to Hong Kong?
Yeah. It is a challenge with always, right? A different culture, different language. So we have to do with what we have, either an English or a Cantonese-based assessment. But if I can, at least the language we overcome by translation, right? It's even the other day, one of my colleagues assessed a Putonghua-based family's child in Cantonese. And I said, how could you? The poor child has no idea how to speak Cantonese at the moment, right? So we have that difficulty. So we adapt. We sometimes adapt to nonverbal tests and rely on those and put the language aside, right? Language is very, very important, as you know. And like I said, we use cheer if we don't have it in-house.
Yeah.
There's problems with that, using translators and interpreters, but it's the best we can. But then we do emphasize a lot on nonverbal communication even, right? But also, of course, the fine motor, gross motor, the socialization. And then it's also good to see if we can put them together within their community. Again, it's very important. Go into their community and observe the child there. Wow. I always ask the parent, how do they communicate with their brother and sister or with auntie or grandma? right? Because that gives you a bit of an insight. But it is challenging, but I think we get the picture. If there's a global developmental delay, of course we will see it.
Yeah, sure.
Yeah.
Leslie, what is your experience? I mean, these might not be a big problem now because they're just born. But I learned from my colleagues in the NICU, the SCB, etc. They're getting more and more. I think we are seeing the same problem as we saw in the new immigrants or newcomers.
About the language, right?
No, not just language. I mean, development is about many things.
Yeah,
but they are from Pakistanis, Nepalese.
Yeah.
So do you feel that it's an extra challenge, or you have any experience?
Of course. It depends on the level of severity. For the very severe case, I think it is the total communication, not just the oral language. And for overall development, they learn through interaction and communication. And also, I agree with Yvonne that the mother tongue is important. But on the other hand, if their plan is to stay in Hong Kong for long, then they need to learn Cantonese and reading Chinese.
I think we should prepare for that. I think for relatively normal children, that is already a challenge. But for those in borderline development and also limited intelligence, etc., that would be a big problem. Because this is new to me. It's after my retirement that they told me that more than half of the babies are coming from non-Chinese ethnic origin.
And on the other hand, their cultural belief is quite fixed, so we cannot change with one-off assessment. They believe even a very severely delayed kid will pretty normal according from them.
Yeah.
So it takes time.
Yeah, but it's good to see. Recently, we had a little boy who came to us with non-verbal skills. We got him to have some verbal skills at the age of 5 or 6, and he transitioned into an SEN local school. And it's nice to see that they have to deliver their curriculum in Cantonese, but they're bending backwards to build a bridge. So when he learned counting, he can count now in Cantonese up to 10. So we're very proud of him. But they built a bridge where they taught him a little bit in English, so 1, 2, 3, 4, and then Yat Isan. So it was in parallel. So they really tried to get him, or not, still trying to get him gradually into the Cantonese environment more and more. But it's tough.
It is great to learn multiple language at very early stage,
yes.
But very challenging for a very severely delayed kid.
Yeah, to agree.
There is a question from Dr. Wan Gamming. He said that he's a general pediatrician, and he said he know little thing about child development, etc. Yvonne, you just tell us that our role is not high, it's not that much in the center, providing the service apart from common medical problem. Is there any training program for general pediatrician about practical issues on behavioral education, so that we can also put some effort in teaching the parent for tackling the behavioral needs of the children? I think it's very true. First of all, in many other centers, there are honorary pediatrician visiting. Do you have such roles in your CDC?
Not yet, but we have been known to. You can see we have very unusual, let's say.
I think you
roles.
should. I think
we
you
would
should.
love to.
Yes. Because I've been involved in Hip Hong and also in the other Haven of Hope for many years. Actually, it's quite rewarding actually to see the children and the parents in the center with the staff.
Yes.
So they understand what our perspective is. So many of them actually are private practitioners. I think you can invite Dr. Wen.
I'd love to. I also give some seminars on how to talk to parents, definitely to teachers even, right? How to tell a parent that they suspect, even at this stage, that their child should have an assessment. So yeah, we can do that as well.
That's on the role of honorary consultant because they would make certain diagnoses. They would help the center to to talk with the parents. Sometimes they need a second opinion, etc.
Exactly.
And they would be more ready to take up whatever the plan would be. That's the point number one. Point number two is that, for medical students, I think they should go there. I think some of the students, they want to go to Watchdog. I think perhaps you can also try to arrange some students.
Yes.
Now that we have 295 graduates per year from each university.
That would be a great addition. We have a lot of interns from the teachers, from other therapists, but that would be a great addition.
Because we work as a team.
Yes, exactly.
I think that's really, really important.
Yes.
And they have to know about, diversity of development in children. The other thing is that perhaps you should ask the minor ethnic group. There are some doctors from there actually. Perhaps they can help. So I think that would be very helpful.
Yeah.
But I'd like to ask Leslie.
Can I add on my opinion first? So I want to add on, as a pediatrician, I'm not only managing medical disease and giving drugs. I really learn from the brain to the behavior.
Yeah.
So we use the ICF model. We are not treating the test score, we are treating the participation. So that's the view of a DBP.
Yes. Yeah, that would be very enriching, I think. Yeah, agree.
So what would be the experience in Child Assessment Center? First of all, involving the other medical pediatrician doctors. The other thing is teaching, etc. May I ask you to take this opportunity to explain? We learned that there is some change in the structure of the Child Assessment Service. When I was a very junior doctor, I went to Aaron Street, for familiarizing myself with the Child Assessment Service. But later on, it would be the Department of Health. And then I understand that you are venturing into some treatment services, etc. And then lately there are some research as well. And with the recent change in policy, I think some of the services in Department of Health actually are now transferred to the hospital authority. So
you are asking the question to a wrong person. I'm retired now, and I'm not in the steering group. But all I know is all the clinical service in Department of Health will move either to the hospital authority or under the primary health care. So CAS is one of the clinical services which will move to hospital authority. And the timeline, from what I know, will be next year. And we are now under an interdisciplinary approach since my mentor, Dr. Lam, and I'm not sure how it will continue in HA. So that's what I know.
So I think the other colleagues should be aware that there is a change in the service arrangement. And there are also increasing demands, expectations from the general public. So I think, Yvonne, you come in a very right position, right time. That I think some parents might like to seek, second opinion, or they want to have earlier assessment. So that's really important.
And the thing is, for a general pediatrician, we need to know is. DBP condition can be ranged from highly complex medical condition to very community-based, such as so-called language delay. Now we call it language difficulties. It will be the majority, which should be managed in the community, I think.
Yeah. So, Dr. Wen went on to say that it would be good if some training for the general pediatrician to directly attend your center and join the classes so first-hand learning can be achieved. So maybe, Yvonne, you can consider inviting Dr. Wen as an honorary pediatrician.
That sounds good. It's just be prepared. We're not a medical model.
And can you imagine a dog in CDC?
Anything. I think that's one of our strengths. We're so flexible, and we've grown over these 50 years by being flexible and enriching and adding. I think this would be a great addition.
So something I'd like to clarify. Say, for example, you assess a child to have special education needs, and then you are running a EETC and SEC, right?
Yeah, only EETC.
EETC. So if you find that the child need SECC or later on a special school, so what would be the logistics? What you would do to facilitate the waiting, etc.
Yeah, it depends. There's several factors. One is who's the referral source in the first place, who referred the child to us. Usually we have to go back to the referral source. So if it's not us, then whoever referred in the community, we need to go back and talk to that person. Well, first, of course, we talk to the parents, right? Get parent consent, that's a given. And it's also the age. If there's a child is over 5 now, we can put in, again, through the referral source. Interesting enough, some of the referrers close the books. When the child is in our center, they close the books, right?
Yeah.
So that's a known one. And so then we pick it up, and then if the child's over 5, we can put them in the so-called express lane. We can ask for express referral so that they get priority.
So you work with the Education Bureau?
SWD, Social Welfare Department.
Social Welfare Department,
Yeah. So they have sort of very rigid tracks, let's say, what you have to do, the steps. But yeah, we have pushed for families, from the EM track, for example, that had no idea and they needed to be expedited. So we have to talk
all
to
I
them.
learned is all the English-speaking service have a long queue. So you jump queues?
We don't jump queues. We can, only if it's age-related, right? When you're 5.
But you're 5. But
5.
You should not.
Then you can.
I know the 5, yes.
The 5
because
years
the
old.
EM family also only bring kids
they bring it so late. I have seen
after the
5-year-olds
after the teachers comment.
Yes.
Yeah.
And then we only have that little window. Once they're 6, not on their 6th birthday, but if they turn 6 by the end of August that year, then they're out of the SWD's range.
But what I learned is the international school start at 5, so you end at 6, right?
You can't. The moment you enter primary school, also SWD will say
So the
stop.
point is, when they enter primary school at 5, then the ETC, it will be stopped.
Yes.
Oh.
Yeah, has to stop. So then we hope that either the school has resources or they enter our self-financed center, where we still have children, 6, 7, 8, 9, and up to 12, we still have them. Or they get services through the EDB, the Education Bureau. So
I think it's kind of tricky. I mean,
it is.
Yeah.
That's what parents need help with. They're to navigate these tracks, right, and who to go to.
Because the agencies they hate me because I refer them very early to ETC very early. Now at those days we do not have OPRS, so I just almost like refer most of the at-risk cases to ETC. I'm glad that recently, in the recent few years, actually. The government actually established more ETC and SECC, and some of them are combined. So I think that's good. But I think I'd like to take this opportunity to say that beware of these children coming from ethnic minority. We have no experience. They come from very diverse background, and we do not know how to train them. So that would be a big problem.
Yeah.
Later on, I think that's my personal bias.
Before training, we need to understand their culture.
Exactly. We have no knowledge at all.
We have no knowledge of the culture.
Yeah.
The upbringing is very different. What we might have called an ADHD kind of profile is quite the norm for them because they don't mind their child running around, right?
It's the norm.
It's not, the behavior is the norm. They don't interfere when a child, shouts.
And they do not understand. You think that their attention span is short.
Yeah, it's a very different perspective of the same behavior. It's just they do it later. They don't see the need to what they think is restricting the child. So it's just a different way of looking at the same behavior. So we need to sort out what's a true ADHD profile and what's just a parenting different behavioral profile.
I think it's the functional impairment, right?
Yeah, it's very difficult sometimes.
Perhaps my last question from myself is that, with the whole population should be AI familiar, that I would like to ask both of you whether AI could help us to help the parents to diagnose developmental delay earlier. That's the number one. The second is that could AI help to train the children with developmental delay?
Well, I'm very conservative in that sense. So I think at best it might help us gather. So when I do a diagnosis, and I have to take so many things into consideration, AI might help me to put all the points together that I need to consider. But that decision making, I don't put my faith into AI, I have to say.
Well,
there's the nuances that AI cannot give me.
Well, I actually asked the same question through AI. The answer is AI actually help a lot with all the data we put in and doing the analysis and actually give us a report and training proposal, right? But the thing is, who put the thing in the AI and who interpret the results?
Okay, so let's keep an open mind for this.
Yes.
But I think there's something that is very very useful. I said because I also asked the parent, normal children, normal babies. I asked you go to the Department of Health, Family Health Service website. They have the normal development of normal children. Yeah. So they should understand that first. Okay, say for example for a half-year-old, for a 9-month-old, for 1.5 years, they should understand what is the normal development for a normal child. And then if they have concern, either you take the child to see a doctor or learn more about the children. So I think we are training the general population to take care of their own problem first. So I think AI in that aspect might help. So today I'm very fortunate to have both experts coming to the studio for this wonderful talk. So we have more than 400 audience at least. So I think they have learned a lot from your talks. So I've prepared a little souvenir for you, Yvonne. This is in Chinese, cultural program.
Oh, thank you. I love it. Thank you so much.
Child first, okay. Child first.
Very
okay,
good. Love it.
Leslie already had one. Winnie, you have one. That's for you.
Thank
That's
you.
a souvenir for you. I hope that I can invite you again. In 9 months or 1 year, perhaps you, to follow up some of the observation we just make. Perhaps I am wrong that we do not have that many ethnic minority children.
Right.
But I think some of them may come to see you.
Right.
So that's a number one thing. The second thing I like to know if you have some doctors helping you about medical perspective.
That sounds great.
Yeah,
yes.
I also like to see that some of our medical students actually have the opportunity to see how you work. Yes. Because I think we teach the student how to do a physical examination. We never teach them how to do a developmental examination. I think we cannot learn that from the medical school. I think you have to learn that from, just you mentioned, from the waiting room.
And also be cautious about the red flag and warning sign.
Yes,
I don't believe all.
No.
You need to take it in person, how you feel.
Yes, there's a lot of sensitivity you develop over years. So I'd love to welcome them. Thank you for the opportunity.
Thank
again.
you. So.